This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So we'll go on to the next talk. We're doing something a little non-traditional in this program this year. Our next speaker is Dr. Andy Paso. Andy is a very talented transplant surgeon who also heads the islet cell transplant program at UCSF, and also the co-director of the Bariatric Surgery Center. He's going to talk about islet cell transplant for patients with chronic pancreatitis. I'm sure that it will be a great deal of interest for the gastroenterologists in the audience. Andy.
Thank you, Francis, and welcome to Silverado. I hope you have a great weekend. Tony, that allegory to ravens in the tower, were you talking about us? Or because if you clip our left wing, we can't operate. So you have to figure out a different way of keeping us here. Yeah. Okay, well, as Francis mentioned, this is not really a talk about transplant, in that the things that we transplant here, the islets, are the patient's own islets. It's more, but it is a transplant in some way, and it's more a discussion of one of the better and newer ways of treating chronic pancreatitis. I wanted to kind of go through the talk by discussing the indications for total pancreatectomy and auto islet transplant, going over the outcomes, which are mainly from Minnesota, the University of Minnesota, which has done most of the auto islet transplants over the last 15 years or so. And then also discuss how this has opened up some research possibilities relating both to auto islet as well as allogeneic islet transplant for diabetes. And finally, just a brief mention about our program, what we've done to date in this field. As you all know, the chronic pancreatitis is a benign disease. It's ongoing for long periods of time. Really, the main characteristic is terrible pain that requires narcotics, really interferes with lifestyle, work, leads to malnutrition and weight loss, and if it goes on long enough, it will cause some endocrine insufficiency and leads to diabetes. The symptoms are relapsing, they come and go. Patients are miserable most of the time, as you probably all know. Here's a picture of what the histopathology is. This is, sorry, let me find there it is. So the top picture is this is actually a part of a total pancreatectomy procedure, but this was an annular pancreas, so there was really not much inflammation going on yet. And you can see that the lobular structure is preserved, and it's a pretty large organ, whereas if you look at the chronic pancreatitis organ, it looks like it's really the size of a small shrimp. It's tiny, it's very fibrous, it's firm. And this is reflected in the pathology. You can see nice acinar tissue there with preserved islets, whereas when you look down at the chronic pancreatitis organ, there's really just scar with some preserved ducts and islets here. The etiology is primarily alcohol, heavy alcohol use for a long period of time, maybe in 60 to 70% of patients. Then we don't know what caused it in another 20 to 30%. And then there's various anatomic and metabolic abnormalities, such as pancreas divisum, autoimmune pancreatitis. In children, you see a lot of genetic polymorphism, so CFTR gene abnormalities and the SPINK mutation. Incidence is about 8 to 10 cases per 100,000. Lots of hospitalizations every year in the U.S., 22,000. That's mainly related to pain control and endoscopic procedures. It's mainly in adults, but as I mentioned earlier, there's some children who get this too. And it's mainly a male disease, although in kids you see a pretty much one-to-one distribution. This is a graph that shows what happens if you let the pancreatitis go long enough. So in addition to the exocrine insufficiency and the problems with pain control, you will eventually see diabetes. And this is actually one of the reasons why it's beneficial to refer patients for the total pancreatectomy and auto-islet transplant early on. At 10 years of chronic pancreatitis, maybe 50% of the patients will develop diabetes. Now, these patients will remain C-peptide positive, meaning they have enough islets to make C-peptide, which is an important consideration later on, but they will start needing insulin. Treatment options, again, I think you're all familiar with this. It's mainly based on treating their pain, so narcotic pain meds. Sometimes replacing the enzymes helps. There's various procedures such as celiac plexus ablation that people have used, but these are not permanent treatments. The pain comes back. Endoscopic therapies are the mainstay, and pretty much all patients who end up being referred for total pancreatectomy have undergone at least several endoscopic therapies. The surgery literature is pretty full of various approaches to trying to treat this disease, including Pustos, which open up the duct, partial resections, and so forth. And really none of these have been shown to be really that effective in treating the disease. And now the total pancreatectomy and islet autotransplant is a newer approach, and does seem to be more effective. And it really evolved over several years and different people trying it. I think the main goal obviously was to try to relieve as much pain as possible and develop a technique that's the most effective in relieving pain, but also preserving at least endocrine function. The Whipple and the Pusto and the distal pancreatectomy all preserve function, but they've not been really that successful at relieving pain, particularly the Pusto, which is probably the most commonly performed procedure. And in addition, you need to have a certain type of duct to do the Pusto properly, a large duct, and in small duct disease or where there's a lot of strictures, this procedure is really not that effective. Total pancreatectomy does relieve the pain very effectively, but again, you remove everything, so the patient becomes diabetic, and these patients have absolutely no islets, so they have no insulin, no glucagon, very brittle diabetes, and they're very difficult to control. So the islet autotransplant with the total pancreatectomy, which started in 1977 in the University of Minnesota, was really, the goal was to, and at this point, islet isolation capacities were improving and people were able to isolate good amounts of islets from human pancreases. And it was really thought that the goal was to really provide the optimal therapy for pain and then also return some of the islets back so that you wouldn't have brittle diabetes. And in addition, as an offshoot from that, people found that by doing this in one patient, so not doing an allogeneic transplant, you could really study function of the islets after transplantation free of drug toxicity or rejection or autoimmunity, which is what you'd see in type 1 diabetes. Our indications here and at other centers are quite stringent. The patients really do need to have chronic painful pancreatitis that is disabling and has not responded to medical or endoscopic therapy. We have to exclude other causes of pain, obviously. They need to be on narcotics and or have a significantly impaired quality of life. And optimally, they would be not diabetic, although if patients are diabetic, we check their C-peptides, and if they continue to make insulin, as measured by positive C-peptide, we can still isolate islets from those organs and give them back to the patient, so their diabetes is better controlled than if they didn't have any islets returned to them. And then finally, the patients really need to accept the risk of diabetes and need to understand how to manage it afterwards. This is the procedure. It's a little different from the diagram, but essentially we remove the entire pancreas and a portion of duodenum. Most centers also take the spleen out because it's difficult to preserve the spleen, although if you can try to do a spleen preserving procedure where the spleen lives on the short gastrics, but often these patients have partial thrombosis of the spleen, which can be quite painful. So we generally take the spleen out and connect the bile duct back as you would in a Whipple, let's say. Often put in feeding tubes since these patients really have poor oral intakes beforehand. And the procedure actually is simpler than a procedure where you partially resect the pancreas since there's no pancreatic anastomosis. And that's really the anastomosis that causes the most problems in most patients. While the patient is getting the reconstruction performed in the OR, the islet team takes the pancreas back to the islet lab and we go through a number of steps to isolate the islets. and have them ready. It usually takes about 3 to 4 hours to do that. So there is some waiting for the recipient in the OR, but not that long. Bring the islets back, and then while we're in the OR, we infuse them into the splenic vein stump. So this is a patient who's had his pancreas taken out. Head is to the top of the slide, feet are to the bottom, liver's here. Here's the portal vein, and then here's the branch of the splenic vein that's been ligated. And we just put a cannula into that splenic vein and infuse the islets. They go in over about 10 minutes or so. So it doesn't require a separate procedure. And we've actually done this with patients who have their surgery done at another center. So we collaborate with UCLA. They'll do the pancreatectomy, bring the islets up here, we fly them back, and it can actually all be done in one sitting. The pain relief that you see with this is quite good. It gives pain relief to the majority of patients. It allows most patients to wean off narcotics. We can preserve at least some insulin secretion in most patients, and they all really feel like it's helped their quality of life. We're pretty good at identifying patients who will benefit, but again, there's some issues, particularly with how many islets we would isolate and what the likelihood of diabetes will be afterwards, that we're still trying to sort out. Just some of the results. I focused mainly on University of Minnesota since they've done the most patients. They have the greatest experience, so I think there's a better, more objective view of what's been going on. They've done over 400 patients. It's interesting, most of their patients are women. And really all of them, all the total pancreatectomies they've done have been in either non-diabetic or C-peptide positive patients. Most of them had either endoscopic therapy or pancreatic surgery. Pretty low in-hospital mortality rates of about 1.2% and good survival of the patients. There were about 16% complication rate, and that's mainly related to bleeding. I would think all the patients need to get heparin after the procedure, since the islets, putting islets into the portal vein increases your risk of portal vein thrombosis. So there's a pretty high risk of bleeding. You have to be quite careful. This graph shows their results in terms of pain control, and you can see the left column is the narcotic use, and the right column is the pain from pancreatitis. And obviously most patients have that before surgery. You can see it drops down dramatically over 2 years to about 50% using narcotics, and many of those patients are actually on very slow weans, and maybe at the lowest, about 10% have persistent pain. There is some increase afterwards, and I'm not sure what this is due to, but it still remains quite low compared to the pre-surgery state. When you look at their quality of life, again, it's dramatically improved. And in about 80%, the quality of life is improved. It's the same in about 15%, and it's worse in about 5%. The quality of life improvement is also increased if you can come off narcotics, as you would expect. And you can see that in the blue lines. Patients who end up coming off narcotics have a much improved quality of life, both socially and physically. And when you question these patients, even if they become diabetic, the 98% would prefer diabetes to having the pain, and 98% would have that procedure done again if they required it. So islet function after this procedure. Overall, independence rates are anywhere between 25 to 40%, and even in the patients who are insulin dependent, they have low insulin needs, and make C-peptide in over 90%. And it's hard to describe, but having at least even a few islets really changes glucose control. There are no lows because the islets it's like having a insulin pump that is very sensitive to your sugars. And you have the counter-regulatory hormones as well that help with your blood glucose control. So who becomes insulin independent? Well, there's several predictors. I think the most important and most obvious is the islet number that you harvest from the pancreases. If you have more than 5,000, so the human pancreas has about 1 million islets, and a good yield is maybe over 500,000. in a normal pancreas. So if you have a 100-kilo person, so that's 5,000 per kilo, most patients in the allogeneic situation need about 7,000 to 8,000 islets to become insulin independent. In the auto-transplant situation, you get about a 70% independence rate with 5,000 islets per kilo, which is actually a reasonable number of islets to procure from a standard pancreas. As the number of islet equivalents drops, the insulin independence rates go down, and you can see if you get less than 2,500, it's about a 15% independence rate and a 60% rate of function, so making C-peptide. Prior surgery is another important predictor, and this is one of the reasons why we try to get these patients in early after they've had endoscopy, but before they've had surgery. Really, the yields are much reduced after surgical manipulation and removal of part of the pancreas or opening the duct up and so forth. Age makes a big difference. Pediatric patients do extremely well after this procedure, and a lot of them have very high insulin independence rates, and it may be related to, in part, to regeneration of islets in these children. And then finally, how long you've had the disease, obviously, how fibrotic your pancreas is, what the islet isolation process has been, and whether there's underlying insulin resistance. This is a graph that shows you the insulin independence rates. So if you look at the different columns, the red is less than 2,500, the orange is more than 5,000 islet equivalents per kilo, and you can see the independence rates go up from about 30% at 6 months to about 70% at 3 years. And I included this line here that shows the independence rates for patients receiving allogeneic islets. So patients who have type 1 diabetes get an allogeneic islet transplant. It's the exact opposite. The independence rate goes down. These are transplanted into the same site, but the difference obviously is immunosuppression drugs, alloimmunity, autoimmunity, and immunosuppressive drugs. And I think that's what probably causes these islets not to do as well in the long term. When you look at insulin, glucose control and C-peptide production, again, there's a much higher incidence of both of these in even patients who receive low numbers of islets. There's about a 70 to 80% C-peptide production, and you can see control is excellent. Hemoglobin A1C levels are between 80 and 95% are less than 7. So even some function helps. And this graph just shows you graphically the differences in islet yields depending on what kind of surgery you have. The worst is the pusto, which is basically an lateral opening of the pancreas and then sewing a piece of bowel to that. The reason it's so bad is because the digestion process requires infusion of enzyme through the duct into the gland, and it requires distension of the gland so that the exocrine tissue is digested and the islets are not. With the pusto, you can't do that, so you're just left with chopping up the gland into small pieces and hoping that it digests properly. And the yields are significantly worse. And as I mentioned earlier, one of the things we're struggling with is trying to figure out how to find those patients who will benefit the most from this procedure in terms of pain control as well as treatment, prevention of diabetes. And we do have some tests. This is a test that's the acute insulin response, which is done with intravenous glucose or arginine. And you can see that we are now able to predict the islet yield that we'll get from a pancreas, all things being even, according to what their acute insulin response is. And we use this as a guide to both educate the patient about what it's going to be like after the procedure, and also to select patients who might really benefit from this. Now, a little different subtopic, total pancreatectomy in children. It's a relatively new thing that's now being done more and more frequently, and it's really been found to be extremely effective. Pain control is great, quality of life is improved, and actually the rates of insulin independence are a lot better since a lot of these patients have not had a lot of surgical intervention. This is a graph that shows against quality of life with the SF-36 in these patients. You can see there's a marked improvement in quality of life. Here we see school absences due to health, and also limited activity levels drop down quite significantly after the procedure. And the likelihood of insulin independence is very high. This graph shows the number of islets. So on the y-axis is the number of islet equivalents per kilo. On the x-axis is the age, and you can see that the triangles are the independent patients. You can see that below age 10, the vast majority of patients become insulin dependent. And we found that about 85% of children who are less than 10 years old have documented insulin dependence, and that is long-lasting. It's not something that disappears after a couple of years. So compared to allogeneic islet transplantation, which we do for type 1 diabetes, we see, in that situation we see very high rates of function, so most of them become C-peptide positive, and they develop early insulin dependence at around 80% at 1 year. But the downside is they need chronic immunosuppression. Insulin-dependent rates drop to about 50% at 3 to 4 years, and we're not sure what the etiology of that is. Is it the site? Is it the immunosuppression? Is it the autoimmune phenomenon coming back? And it allows us to study the islet autotransplant to see what factors do play a role. Just to give you an example of what the potential of an islet transplant can be, so this is much better than what we see in an allotransplant. The longest documented period of insulin dependence has been 16 years after an autotransplant, with most recent hemoglobin A1Cs being normal. The highest amount of insulin production by a graft has been also documented in an autograft with C-peptide levels of 15. So usually in the allo situation, we see only at the most maybe C-peptide levels of 7 after stimulation. And this is basically a normal response. We found that in looking at these children, we found a regeneration of islets after transplant. So this photograph shows an islet on the right side, so you can see the green stained insulin beta cells. And then this is a duct, or a islet structure that's surrounded by fibrous tissue that you see in a duct. And you can see there's insulin staining cells in there. And I think this is one of the things that's responsible for the good outcomes that we see in children. And finally, we've been able to use the model to try to understand what it is about the isolation process, about the transplant process that affects islets. Why do they not work in the long term in the allo situation? And we can look at it here because we don't have to worry about the other immunologic issues. And this is just a graph that shows what the differences are. The red lines here show the insulin dependence rates for an allogeneic islet transplant. So over 1,000 days, you can see they drop down to about 25%. And then the blue line shows auto-islet transplants. And you can see independence rates are 75% at over 3 years. And it really can't be due to the transplant site, which is one of the big debates that had been going on. It's most likely due to donor factors like brain death, maybe cold ischemic time. It's probably also related to autoimmunity. And then finally, we purify the islets more for the allogeneic transplants, and maybe we are removing some of those precursors that I showed you earlier that are in the ducts. It's hard to know, but again, interesting areas for research. And just briefly, this is our experience. So we've done 12 cases so far in the last 9 years, but we've been more active in the last 5. We've done 1 child, and primarily the others have all been adults. We also isolate islets for other centers. We do this on a pretty regular basis. They get flown in and flown out. You see the etiologies, and you see the previous surgeries that patients have had. Our outcomes have been pretty good, I think, on par with University of Minnesota and other centers. We get a good islet yield, usually about 3,000 per body weight. But one of our problems has been that we get referrals pretty late, so a lot of these patients have had surgeries. And you can see we've had our share of about 35 to 40% of insulin-free patients after this procedure. About 40% are completely pain-free, and the rest are on weans. We've had improvement in the other 40%, and about 16 are the same. And this is just our algorithm. We're really trying to push, push the advance after surgery. a bit, so we really try to get these patients out between 7 to 10 days. There's a very specific protocol in terms of weaning from IV pain meds, having physical therapy and all that kind of stuff, and all these services are involved in the care of the patient. So in summary, the clinical goal of total pancreatectomy is really just to relieve pain while minimizing the risk of labile diabetes. Outcomes are obviously better with high yields and with surgically naive pancreases and in children. The independence rates are achievable and they're long-term in most patients. And it also provides a good model to study islet graft function after transplantation into the liver. And these are all the people involved in this program. I didn't list all the pain specialists and endocrinologists and so forth that are involved, and they're very, very important in our inpatient and outpatient management. Thank you. Any questions?
Tony.
Hey, this is a very fascinating and technically challenging cell biological undertaking. There's been, as you know, a lot of development in terms of pancreatic islet cell growth factors.
Mm-hmm.
Is there any room for using those or TP-IAT pathway type of agents to help promote the growth of these islets? What's the
Yeah, it hasn't been obviously used clinically, and I think people are struggling with trying to get islets to grow, human islets to grow in vitro, and they've tried various approaches. The other way to kind of try to improve function is to use the new GLP-1 analogs and drugs that increase sensitivity to insulin. And people have used this in this population, and they found that they can get a lot more people off insulin. So.
Great.
Yeah.
How long do you keep these patients on anticoagulation?
They stay on heparin for 2 days after the surgery. I'm sorry. Question was, how long do we anticoagulate them? 2 days on heparin after surgery, and then 2 weeks on Lovenox when they go home, and then we stop. Obviously, if they have a thrombosis, they get an ultrasound, and if they have a thrombosis, then we'll keep them on longer. But when they do get a thrombosis, it's usually partial, one side, non-occluding. It's that kind of thing. Thank you.
Thank you.